So this lesson is going to be on documentation, and this is going to have multiple parts. The first part here is going to be an overview that I'm going to do very briefly, just to give some highlights and some context. Then I really want you to spend some time watching the other videos that I've posted as well. Because although this is probably not the most important lesson when it comes to what we've been discussing here in administration, it is probably the most important lesson for you in particular because of the way that we have our program. We emphasize collegiate athletics, and you guys do a lot of practicums within the Augustana Athletic Training Room. And as you can tell, documentation in the Augie is very different from normal documentation because of the unique fact that it is a college athletic training room, and they use different techniques as well as they do very specific patient care where the provider is basically the same person over and over, and so they do not need to do as much documentation for consistency of care. Now, that being said, there's obviously other reasons to do documentation, and we will talk about that as well, but you need to be prepared for much more robust documentation procedures. So let's go ahead and start with what this looks like. So first is what the medical record is, and really the important thing to understand here is that the medical record needs to include basically everything that occurs with that individual, right? So not only their history and physicals and current health problems as far as injury reports, but also what interventions they've been getting, right? As far as specifically what modalities, rehab they're doing, how much, different aspects with that, as well as documentation of communications with them. Now this can become difficult with large volumes of communications if you're talking with individuals on a regular basis. That would become difficult, but understand that you are making an exception anytime you don't document a communication, as well as any billing records. And that's not as common in athletic training, but you probably need to be ready for that because at some point in time it may be, specifically with this idea of global billing that has got some attention recently. The idea that opposed to procedure-based billing, which occurs right now, this idea of global-based billing, athletic trainers may become much more involved in the billing process, and we will discuss more of that in the next unit. But when we look at medical documentation, we really go back to 1993 as the beginning of this current age, where we start the process of getting this electronic healthcare database. And although the goal was by 2014, we still have some work to do, but there is much more progress. Most of the work right now is having multiple systems speak with each other. So oftentimes a lot of these goals have been reached within a single organization, right, where you're able to view x-rays or patient notes from other providers within your organization. But if a organization uses a different electronic medical record, then you may not have their information from previous physicians outside of your area. And so because of this move to electronic medical records, we also had an increased need for privacy, because in the past the only way you could get a medical record would be to physically break into the institution and look up that patient's file. Once these things start being stored electronically and transmitted electronically, obviously that increases increased need for security. And so the Health Insurance Portability and Accountability Act, or HIPAA, was signed into law in 1996 that really governed this electronic medical records. And so there have been multiple rules and standards that have gone into effect, but HIPAA is the law that governs these electronic medical records. And any healthcare entity that bills electronically, which is basically the only way that most insurance companies accept billing in these days and age. So basically, if you are billing for your services, you are affected by HIPAA. Right? Some organizations that don't transmit electronic medical records fall into some of these gray areas, a lot of colleges and universities. But in that case, they might also be governed by FERPA, which is the Family Education Rights and Privacy Act that governs educational records. And so it's important to understand what this HIPAA is, and you're going to follow the intent of HIPAA, if not the letter, regardless. Now, the important thing to really understand with HIPAA is that it is much more complicated than just patient privacy. You need to think of HIPAA similar to, like emergency action planning. It is a process that needs to be put in place to ensure that healthcare information for specific patients are handled in a way that is consistent with the wishes of that patient. And so because of that, you have to gain these waivers and privacy policies beforehand. That's why every time you go and see a physician, one of the first things that they ask you to do is they give you access to their privacy policy, which is required under the HIPAA law. And they then ask for your permission to bill your insurance, which is giving you as the provider permission to transmit their protected health information to their insurance company for the purpose of billing. Another thing to keep in mind that's really important is if you are working for an organization that is required to maintain HIPAA compliance, one thing is that you must have a designated privacy officer, right? And so these designated privacy officers are the people in charge of ensuring the development and proper following of institutional policies. And so that is your guidance. Another thing is that it is possible that a patient refuses to sign an authorization for release of medical information, and you are not allowed to deny treatment for that reason. However, you can preclude an athlete from participating ahead of time if they do not allow authorizations in internal sort of things. So there are exceptions to that, but keep in mind that every piece of private or protected health information needs to be released, and you cannot deny things based on that. Patients also have a right to request their medical records, and they can get that in electronic format for a nominal copying fee. But with that, there are also a whole bunch of other gray areas as far as what is medical information. And the rules are a little outdated for how things are, but you need to think that anytime you're communicating with an individual via your phone, right, that is an unprotected mechanism. So if you're leaving a message, you need to leave the least amount as possible, right? And text messaging, right, you can't assume that they're the only ones that can read that text message. So you need to consider text messages similar as to messages, basically just confirming appointments. Now, obviously, that changes slightly, but that is the true HIPAA guidelines. And so in these athletic population areas where we're not necessarily bound specifically by HIPAA, that's where we can follow the intent of HIPAA without maybe necessarily the letter of HIPAA, understanding that in today's day and age, cell phones are probably more protected than previous email and different aspects there. So this idea that messages and text messages are not secure is a little bit outdated. All right. Another thing to keep in mind with that is in public areas. It's important that patients have the ability to request a private treatment area. Just them being in that area receiving treatment is a disclosure of protected healthcare information. And so things like medical files and schedules should not be left face up. People should not be able to go into your facility and have any idea of who else may be coming in later or had been there in the future. Now, obviously, group treatments are acceptable as long as the patient agrees to that. But you should not be like leaving notes or anything for other people that can be seen by patients. And then lastly with that, because the amount of HIPAA information and HIPAA regarding entities are so vast, it's very difficult now. It's very difficult, sorry about that, it's very difficult to, in fact, then catch everyone. So instead, what occurs is if you are caught, the penalties are very stiff. And you can see some of these penalties listed here with that. So, and these are per instance. So if you are not following HIPAA guidelines, it gets very expensive very quickly. So moving on from HIPAA, this is something that should be completely reviewed for you. So I'm going to move very quickly and instead just tell you what you need to know and study on your own if you don't remember. Also, the other videos will go into some more in-depth analysis of these as well. But the first thing that I really want to make sure you focus on, so I'm going to hit it here and then it will be the focus of additional videos, is the idea of documenting not only clinical findings, but more importantly, impairments and functional limitations. Right? So when you're doing an evaluation, right, one of the big differences between athletic training and physical therapy or other rehabilitation or healthcare providers is the fact that athletic trainers routinely assume that they know the patient's goals and or understand the limitations that are placed on the patient. And so as such, when we're doing our documentation, we only document our findings based off of the examination. We don't document their actual limitations or impairments. And these limitations and impairments are what they cannot do as a result of their injury. So if they have limited strength, right, we all know that we would document a decrease in strength. But we should also then document that that means that they may not be able to run or jump or play their sport. Those are things that now become important, specifically when you're asking somebody else to pay for your services. Because an insurance provider does not provide insurance so that people can maintain their strength. They provide service or insurance and pay for services that allow individuals to return to their normal activities of daily living. That's the important thing. They don't pay for return to sport, and they don't pay for just structural changes as far as like decreasing swelling. It all has to be linked to an impairment and a functional limitation. So when they're talking about that in the other videos, pay particular attention to that. Although it's not, common in athletic training, I have a feeling that it will be in the future. With that, pathophysiology is what we normally focus on, right? The medical diagnosis. But those disabilities and social limitations are the next step with that. And that goes back to our ICF disability framework that we talked in techniques in athletic training. So if you don't remember that, go back and look at that ICF model as well. And that's all there from this idea that this is what is going to be required if you ever want to bill for your services. And like I said, that may not be the case now, But if we go to global billing or different aspects like that, it doesn't make sense for the insurance company to save money because you're providing the services for free, right? You're not saving your patient money, you're often just saving the insurance company money. So at some point in time, if there is global billing and the insurance company allocates X amount of dollars for every ACL surgery, it makes sense that athletic departments will start to try to recoup some of that money if they provide the services in-house. So we need to be prepared for 10, 15, 20, 40 years down the road, this possibility. And that's the main focus of that, of the following videos. As far as the documentation, I just want to go through some of the purposes and what goes into a normal SOAP note. When you think of documentation, we talked about a need for billing, but it's also important from the standpoint of communication with coworkers and others involved with the patient, right? The idea that if you were to get hit by a bus and were not able to go into work the next day, how would people know how to continue the care for your patients? And also, another note, if that's not good enough, go to protection from liability, right? If you don't have good medical documentation, then things didn't occur. And so if bad things happen or something occurs, if you don't have documentation, you don't have an ability to prove that you provided care in a reasonable manner. So the initial evaluation is what we're going to talk about here as far as documentation, right? The subjective portion, you need to know what goes into the subjective portion, all these sorts of things, pain level, chief concerns, date of onset. You always have to have a date of onset in a specific month, day, and year format. If they can't remember specifically, you can do some rounding and help, but you always need this, and this is specific for insurance sort of things, or even for athletic aspects for liability. If the date of onset is before the coverage or before they became an athlete at your institution, you may not be responsible for the bill. Mechanism of injury aspects with that, the subjective, all of the different things, right, with that, both past medical history as well as current medical history. A lot of the past medical history can be included, right, in review of systems or your basic physical aspects, right? There's social history, different components associated with that as well. And then basically your patient interview. That's usually what we get. But don't forget those middle sections as well. As far as the objective components with that, right, this chart here is very important, and you need to be able to memorize everything here and know what these different components are. What does a manual muscle test of 2 out of 5 mean? And I will give you a hint, it's not the same as 40%. If you're using a 2 out of 5, most of the time that is derived from Kendall, who originally described it, and 2 out of 5 is the ability to move the joint through full range of motion without being against gravity. So assisted in some way. You would either assist them and remove gravity, or they would move in a horizontal motion. 3 would be full range of motion against gravity. Right? 1 is just evidence of contraction. 0 is no evidence of contraction. 4 out of 5 is against resistance, and 5 out of 5 is against maximal resistance, or the brake test. These are the sorts of things you need to know what we're talking about, because they will show up on the BOC, as well as, you can document your own way if you wanted to do percent, sorts of things as well. But if you document using some of these standard sorts of numbers, you need to make sure that you're using the same definitions as others. Otherwise, you need to define it yourself. Right? So you can define the strength yourself using whatever terms you need or you want, but you need to mention that that is what you're doing. So really, when you do a 5 out of 5 strength, meaning that they had full strength against a break test, really that is 5 out of 5 all Kendall, meaning according to how Kendall described it in the manual muscle tests that you learned. Right, same things with the Waddell scale down here, right? The different grades of point tenderness, right, with palpation. Now you can describe these, you can describe these just using adjectives, or you can describe these using the grades that Waddell already described. So make sure you spend a lot of time memorizing this entire chart. Right? Other things in the objective, right, is any quantifiable sorts of things, observationals with theirs. Don't forget, this is where you include a lot of those functional limitations and activities of daily living, right? They have scales for this, instrumental scales of daily living, right, as far as independent living, sleep, bed mobility, transfers, all these sorts of aspects go into this objective thing as far as your looking for what they can't do. So if you see them limping when they're running, right, even though that may not be particularly important in making your diagnosis, it is extremely important in making your plan. So remember that the initial evaluation is not about making a diagnosis, but is instead about communicating your treatment plan. And so the thoroughness of your evaluation leading into your planning is what's more important. Right? More objective things and functional limitations to consider with that. Right? All of these different things are things that you can evaluate with that. When you get to the assessment is not the diagnosis. I'm going to say that again. The assessment is not the diagnosis. That gets messed up too often. The assessment contains the diagnosis. The assessment is a part of the documentation process and has multiple components in right? The medical diagnosis, impairments, functional limitations, and the prognosis. More of that will be included in the additional videos, but keep in mind, assessment does not equal diagnosis. All right, what each of those are listed there, and we'll go over in some of the more additional videos. And then finally, you end with your plan of care, right? What's going to occur. Within these, you need to include how long each individual treatment and how long the duration, frequency of treatments, right? Intervention list, and then goals, right? As far as all that. Lastly, I want to end with a few specific things that are important for athletic trainers. First, athletic trainers are known for their functional testing. That's one thing that we spend a lot of time with. And there are all of these gold standard testing things that have reliability and validity documented with that. So opposed to just making up your own functional test, look for functional tests that have reliability and validity measures already. Also with multiple patients, there is a group therapy billing code, right? And so if you are treating more than one patient at a time, you need to use a group therapy billing code. In addition, one thing that's important to realize is these codes and documentation things with that are only for supervised and skilled interventions, meaning that routine things that occur and then you just do check marks are not going to be billable activities. And that's why athletic trainers traditionally do not do billable aspects, because we do so many treatments, right, and so many interventions that oftentimes it's not possible for all of those to be supervised and or skilled, meaning that you made a cognizant treatment decision each time. You just do the same over and over again, which is fine for a treatment component. But when we get to billing, the assumption is that you are there supervising, providing feedback if they're doing exercises, as well as making a conscious decision each time for that intervention, right? And so there are now then unsupervised and supervised, right? There are some things that really do not need supervision, but still need to be decided. Like electrical stimulation is an unsupervised aspect. And so that's just a different component with that, right? And so when we get to these aspects in there and we start talking about the possibility of athletic trainers billing for their services, it's important to understand that reimbursement is based off of quality and efficiency, not volume. Right? Athletic trainers often do volume-based treatments. We do a lot of different treatments, and insurance companies are not going to pay for all of those. So unless athletic trainers greatly change their way of practice, or we go to a global billing component, the ability for athletic trainers to bill for their services is not likely in the near future. And so when you get in this, and the reason for that is because of these denial of services, right? Services provided to a patient are denied, right? If the documentation was not completed and sent, if the intervention wasn't deemed necessary, there wasn't and so if it is denied with that, there are appeals options, but you can see from the very beginning, athletic trainers don't do a good job of these first two things. And so getting to these further aspects are more difficult. But if you do have a denial, right, of services, for a brace or something that's being ordered with that, there are abilities to appeal. And so that's wrapping stuff up. There are a few videos that I want you to watch as well that are posted on the Canvas page below here as well. So make sure you watch those. Take some notes on those as well. See what you don't understand, and we will discuss more of that in class. Thanks.